thank you the organizers for giving this, and thank you all for listening at afternoon post-lunch session. So why we are here to study this topic, that is the glucose control, because practically in an ICU, if we go ahead and see, then practically you will find that 50 or 60% of the patients would be either diabetic or having the sugars which are in the range which is not expected. So either it may be hyper or a hypoglycemia or any glycemic variability. Ultimately, it increases the mortality of the ICU patients. So it has been shown that there is a cellular hypoxia which is happening, and it upregulates the expression of the insulin-dependent glucose transporters on the membranes of various cell types, and it results in reperfusion injury due to the high circulating glucose levels. So whenever we are finding a high glucose level, whether the diabetic or not, we'll be addressing this in an ICU patients. And this has shown that it increases the oxidative stress, and it's more detrimental, particularly when you are having a sustained hyperglycemia in ICU. The presentation that I have made is from 2024, the Society of Critical Care Medicine guidelines, and our Indian guidelines, which was made by various stalwarts of critical care like Dr. Yatin Mehta, Dr. Kulkarni. So many of whom are under whom I have been trained and studied. So what level should you be targeting, and what should be the trigger when you are starting the insulin? That would be a persistent level which is like more than 180 deciliter of the sugar readings. And why this target has come is, though for a OPD patient the targets are different, is because of this particular high glucose level, it causes osmotic diuresis and ultimately causes the endothelial glycocalyx problem, and there is a seepage of the bacterial load, and ultimately it causes sepsis and the patients ultimately die. So should you target this 8139? Probably no. The target is little bit more flexible. What sir was already talking about, it is somewhere between 140 to 200. And this is the diagram what I am trying to show, that whatever way you ultimately, everyone wants to reach the goal of managing the patient, bringing the patient back to his home or improving from his problem. So personalized glucose targets are much more better, and we should always look at the pre-hospital glycemic control, what was that of the patient. If we look at what type would you be giving, then we'll always prefer in ICU, particularly in a sick patients, giving a continuous IV insulin. And for ICU patients, we generally use a regular insulin, which is a short acting, which can be easily titrated. We don't prefer giving long acting insulins in ICU patients because of the various multiple comorbidities, hemodynamic instabilities. How frequent you will be checking the blood sugars? Ideally, it's a continuous, that we'll discuss out, but more frequently, less than 1 hour is recommended. You should always have some protocol in your ICU rather than having nothing, and having that will help in your better glycemic controls. Which patients are to be considered that these patients require a IV insulin or this need to be looked after is, one is the patient who is having a HbA1c more than 8.5. That is an indication that the patient requires a significant glucose control needs to be done. Surgeons typically ask that though the HbA1c was 9 but I want to operate, then we generally say no, that let us have the sugars under control for at least minimum 48 hours before going ahead for the surgery, because then the post-surgical complications are significantly less. The glucometers that is being used in ICUs is used for multiple patients, multiple strips are being used, but they require calibration. Generally there is a strip available for the doing a calibration of the glucometer, and whether a glucometer alone is reliable or you need to do something, that also we'll discuss out. Even if the HbA1c was not done, but you're finding that the sugars were like say 200, 180, 250, then it's better that you get a HbA1c done of these patients. And if you are not having a HbA1c, then get it done if it was not done in last 3 months. So whenever you are finding that any sugars, like when the HbA1c is 6.5, then you should consider this patient as a diabetic and treat them like a diabetic patients. The 2 hours post glucose blood glucose value of more than 140 can also be used for diagnosing dysglycemia. So HbA1c cutoff along with the random blood glucose should be used for dysglycemia diagnosis, particularly in patients who are undergoing a major surgery and those who are having at risk. Another thing is that nursing staff comes and tells that, sir, the sugar is very low, but the patient was already in hypotension, the patient was cyanose, and you are taking a sugar from the capillary level, that would never give you a correct reading. So in a shock patient, the patients who are on multiple vasopressors or inotropes, we always recommend taking a sample either from a artery or a venous. And even if the patient is otherwise a hale and hearty, was not a diabetic, we always recommend getting at least once a sugar in 24 hours to know that if the sugars are fluctuating or not. How will you monitor the SS or the monitor dysglycemia in ICU? That would be a 4-hourly blood sample should be taken. The arterial and venous samples are always preferred. The time in target range is an important parameter. So it is not only the values, but how long in the 24 hours range the sugars are fairly remaining in the range that we were expecting. That is important. Look for the glycemic variability and fluctuations that is happening in your ICU patients, and a glucose monitoring, what we call as continuous glucose monitoring device, which is just applied over, and you can get a readings continuously in your app. Because if we consider from the financial angle also, getting every 1 hourly pricks to the patient ultimately increase the burden of the nursing staff, it increases the cost, while here you can get continuous readings of the patients, particularly when you are having, like we manage this for diabetic ketoacidosis patient, when we know that the acetones are high and the patient requires continuously monitoring of the glucose, then that comes to a play. Though it's costly 5,500, but ultimately if you see the long-term cost, it's more cheaper. The targets should be somewhere between 140 to 180. So we have to ride both the horses together, neither too low, neither too high. Generally, for a patient who is fed on a oral fed or a bolus feeding, the recommendations by the Indian Society is somewhere around 7 times a day. And if the patients who are fed continuous feeding, generally what is now being preferred in ICU patients, the monitoring should be done every 4 hourly, and target should be kept that the blood glucose level above 110. Keeping below this causes more of hypoglycemic episodes, and ultimately the patients land up in more morbidity and mortality. When we look at the glycemic index and glycemic load, then there are nutritions which are available, and you should try to give a patient a low GI and low glycemic load rather than an individual carbohydrate focused diets. And this has been not possible particularly for the kitchen feeds, which is more easily possible for the formula feeds. Glycemia targeted specialized nutrition, only just focusing on carbohydrates. It was discussed in my previous speakers also, customize. So that words I am again using, that only focusing on pure low carbohydrates may not serve the purpose. You need to focus on the other parts also, particularly the protein and the electrolyte content of this specialized nutrition, and try to give patients feeds which are having complex or slowly digestible carbohydrates and MUFA that help in more of a glucose optimization in ICU patients. When we talk about macronutrients and the glucagon like peptide modulation, then proteins are known to cause GLP-1 release, and particularly the milk proteins with higher proportions of leucine isoleucine stimulated these GLP-1 secretions. Non-digestible and fermentable carbohydrates, prebiotics as well as short-term fatty acids have shown to increase the GLP-1 levels. High protein digestibility corrected amino acids, core proteins along with complex carbohydrates and MUFA have tendency to favorably modulate the GLP-1 response. So what ultimately is that just carbohydrates are not the only solution to bring your glucose level down, focus on other things also. When we talk about other special cases in an ICU, like a patient having acute MI or a patient having a stroke or a renal failure, the targets again are the same, that is 140 to 180. If the sugars are more than 6.5, treat them as diabetic. Again, 7 times a day for oral fed patients or in bolus feeding, 4 hourly in a continuous fed patient, the guidelines remain the same. Particularly for a renal specific, you need to be having a renal specific feed because they have fluid restrictions. You cannot give a large quantity of volume, particularly through the rice tube. So those renal patients again require a low GI and low glycemic load feeding. So this is ultimately a team effort. As a critical care, I cannot bring the patient out if I am not able to control the sugar alone. So I require a role of my nursing staff, my dietitians, my pharmacist. So it's a team effort that we require for ultimately managing a patient. In an ICU, we always follow the dictum of fast beat, that is feeding, analgesia, sedation. So one of the part is the glucose level and the feeding that we always look after in any ICU patients. Always have some protocol for your particular ICU. And always, like, this conference are must to update our knowledge about the nutrition for ICU patients. Whenever the patient is being transferred from the ICU to the ward, it was under very strict monitoring. There were frequent sugars happening. But for a patient who was in a high risk group, particularly the renal, the cardiac or the neuro patients, they are considered to be high risk and they should be monitored more frequently in ICU patients, and there should be a proper handover between the nursing as well as the doctor from the ICU to the ward about the sugar levels, how they were managed, and what was being given to these patients. So to summarize, the targets for these patients is keeping a little bit a higher range, that is 140 to 180 of the blood glucose. Continuous over intermittent insulin is always preferred. Avoid tight controls and fixed targets. They don't generally help. They actually are shown to be detrimental. Have some specific protocol in your hospital in ICU. Give foods which are low glycemic load and low glycemic index, and ultimately it's a team effort. Thank you.